Welcome everyone. My name is Blake and I will be your moderator. I'm excited to welcome Dr. Fasbinder for a deep dive into restorative materials. Before we get started, I'd like to take a moment to go over some housekeeping. This webinar is sponsored by Dentsply Sirona. Schein is not offering CE credit for viewing or attending this presentation live or on demand. Welcome and thank you for being with us. I will pass it over to you now.
Welcome, and thank you for taking the time to join me in exploring solutions to the short clinical crown dilemma. How, why, and what to do. I'm Dr. Dennis Fasbinder, and I'd like to thank Henry Schein for inviting me to host this webinar on a very timely clinical subject. By way of background, I'm a clinical professor at the University of Michigan School of Dentistry. I also am the director of our CompuDent unit, which is focused on CAD/CAM research, ceramics, and education in digital technology. I also have a part-time practice in Ann Arbor in which I actively utilize the digital systems and the ceramics that we'll talk about. A little conflict of interest disclosure. I do have quite a bit of research grant support for clinical research, as well as honorarium for educational programs from Dentsply Sirona, Ivoclar, and 3M. And just as a reminder, the images used in the presentation have not been altered from their original state. So solving a clinical problem is not unique in any way, shape, or form. This is a pretty common problem for us to deal with, and how do we manage short clinical crowns? Invariably, we're talking about mandibular second molars, sometimes first molars. As you can see in this example of tooth number 18, significantly broken down occlusal surface in need of a restoration. Obviously, you try to do a crown preparation, something like this. Our limit is the gingiva, primarily on the distal half of the tooth, as we realize that that is the limit of what we're able to do relative to where we can place a crown margin. Because of that, we have this minimal occlusal clearance issue that we're constantly trying to solve. We have a short clinical crown to deal with as it is. We're trying to create enough occlusal thickness for a restoration to fit in there and still be able to withstand the stress of occlusion, and we just have limited space there. Another problem we develop with this is, how do we retain that crown? As you can see here, we have very little, if any, reduction on the distal half. The choice was made based on where the soft tissue was, that there was a limit to what could be done. And now you're faced with a situation where you have this very, very short preparation, and you're going to somehow retain a restoration to it. So as we really boil down our essential problems to solve in this kind of a situation is space. We realize that we have a problem with it in general. We're far back in the dentition. Sometimes the teeth are on the shorter side to begin with. We have limited occlusal space, which is a very critical dimension for our restoration, because the occlusal dimension is what ensures that whatever material we use achieves the strength we think it can do. If we compromise that thickness, odds are we're going to have a compromised restoration and potentially a fracture or a chip. Axially, we don't have a lot of room to create retention. So now we have this problem of, how do we overcome these two limitations? What's the best material to use? What's the best technique to get the preparation that we need? And how best should we deliver the restoration in this situation? Well, if you look at the preparation guidelines for the primary materials that we would be considering, adhesive glass ceramics are not generally a really popular material for a very short clinical crown, because by virtue of their strength properties, you need to have at least 1.5 millimeters of them, and it must be bonded. You really don't have the option to cement it. So for most people, this is not one of their primary options to solve a short clinical situation. The two that we look to are either the high strength ceramic or the zirconia. And as you can see, we have a much less dimension required on the occlusal of both these dimensions. But keeping in mind that this is the most important dimension relative to the strength of our restoration. And I say it that way because many people believe, well, the material has an inherent strength. Not really. We can compromise that inherent strength by the volume of material that we create for the restoration. manufacturers give us these recommended thicknesses that we should have for our preparations. And that's to ensure that the strength they tell us these materials have will be there. We can't take one of these materials, reduce it in half, and expect to get the same strength. That's why we have these recommendations. So at least using a high-strength ceramic or a zirconia material, we have a better opportunity to put it in a smaller space than, say, the adhesive glass ceramics. The challenge is what becomes a retentive preparation. We've been taught that back in dental school. What are some key guidelines to improve retention? But really, what makes something a retentive preparation? Now, we're talking geometrically here, mechanically, because sometimes people would prefer to cement these restorations instead of bond them. Now, I wish I could quote you some clinical research to say this clinical project, these research projects have shown that if you do preps like this, your restorations will be retained. We really don't have that. A lot of our knowledge on retention comes from laboratory studies. And so probably the key guidelines to keep in mind is the wall height. A number of laboratory studies have shown us that if the vertical wall of your preparation is less than 3 millimeters, it's not going to be retentive. We talk a lot about taper. You've heard the dimension 6 to 8 degrees, maybe 12 degrees total, side to side. Bottom line, if you try to cut a prep like that and you look down on it as you see these 4 preps, you will say it's parallel or possibly undercut, and you will tend to increase the taper. That's more a function of our vision than it is of anything else. You look and judge taper best in a profile. That's where we're better at in the anterior of the mouth. So generally, our taper is really closer to 15 to 20 degrees when you consider these types of preparation, which is fine. Okay, I don't want to make it sound like, oh, that's too much. That's fine. The other thing we can do to improve our retention is to add mechanical resistance features, such as grooves, such as boxes, some of the old school cast gold and PFM techniques to improve retention, because those features minimize the radius that the crown can come off the tooth. And that's what they're all about, is to interrupt that rolling of the crown off the tooth. And the other thing to keep in mind is that this retention needs to be circumferential. It's not going to be taken care of by just 1 or 2 surfaces of the tooth. It's dependent on the least retentive aspect of the tooth. Now, if you can develop these things in your preparation, you should have good retention, and there's no reason you shouldn't be able to cement it as long as the material allows to be cemented. And that's an important aspect. Okay, here's a good example of an investigation. They looked at maxillary first molars. These are 75 crown preparations done by different general dentists just during their daily treatment of patients. So there was no specific thing designed that cut this type of prep. It was do crown preps the way you do in your clinic. Then they took, these were all digitally recorded files, so they were able to take the STL files and use a computer to assess the different features of the preparation. They discovered that only 13% of the preparations had a convergence angle between 6 and 15 degrees. As I mentioned, visually, those look very parallel to us, and we tend to increase the taper. And so the authors identified this as one of the most difficult tasks, to get a nice taper to the preparation. Especially if you look at the distal lingual area of the tooth, which is the hardest for us to see and access. Those tend to be over-tapered more than any other part of the tooth. When they looked at the mean prep height of 4 millimeters, okay, they found that that wasn't a problem for a lot of doctors to achieve in general, but they tended to have poor retention because they were over-tapered. And it said 30% of the prep showed insufficient occlusal reduction. So we know that even if we're not trying to work on a short clinical crown prep, studies like this show us that the challenge we have in the preparation to be retentive are the 2 most important pieces we have to get right: the taper and the clinical crown height. So with that in mind of what makes something retentive, what is a non-retentive preparation? It's got to be something that we say, nope, that's not going to work. Well, as you can imagine, if the walls are shorter than 3 millimeters, it's not very retentive. And you're going to need to do something to enhance that retention. Maybe some boxes, maybe a groove. Now, these need to be 90 degrees opposed to each other, You can't put them on, say, both proximal, both the mesial and distal, because that'll only prevent it from rocking facial-lingually. You got to put one on the buccal or lingual and one on the mesial or distal to counteract that. If your wallpaper is over 20 degrees, it's probably not going to be all that retentive. It's not going to compensate for, let's say you're at 2.5 millimeters and you think, oh, if I really do this parallel, I should be okay. Remember, that's one of the hardest things for us to get right is the wallpaper. And if you add no mechanical resistance feature, you're left with surface area dependent bonding to be your retention. Now, the good news is we can bond well if we can control the environment. And that's a big if, isn't it? We know moisture is not our friend when it comes to adhesive bonding. But if we have a preparation that is non-geometrically retentive, it is a very good way to create retention if we can follow the concepts of isolation and appropriate use of our materials. So keeping those concepts of the preparation in mind, two hardest things to do is get the taper right, get the occlusal thickness right. We have a lot of materials to pick from. Now, most of these materials are not going to be most people's first choices for a short clinical crown. Probably the two that are going to be the most commonly selected are either high-strength ceramic or zirconia material. These seem to be the two that offer us features that can really be an advantage in solving this kind of a problem. Now, in the high-strength ceramic realm, the newest block into this category is what's called CEREC Tessera. It's an advanced lithium disilicate material, has about a 55% crystal phase, about 40-45% glass with a very small particle size. It is a true color pre-crystallized block, meaning you don't have any crystallization to do in order to get the high strength. It comes in the block form at high strength. Because of that, it takes a little longer to mill, so we're about 12, 18, 16, 17 minutes, somewhere in there. And it has a pretty unique chemistry based on a couple crystal structures within this glassy matrix. You have a lot of lithium disilicate, which are the rod-shaped crystals, which helps increase the material density and interrupts crack propagation. That's where some of the high strength comes from. The other part is this virgilite crystal, which is a very small lithium aluminum silicate particle. It's kind of platelet shaped and it adds to the strength of the CEREC Tessera. Now, since you don't have to crystallize it, does that mean you just mill it and polish it? No. Because it's a hard material and it's milled, we have to ensure that it wasn't damaged during milling, and that's what matrix firing is all about. It's to optimize the physical properties that we get in the block form. Now, a couple of musts. You must use a surface glaze on the surface of the restoration for this to occur well. Because what the glaze does is it focuses the heat of the firing sequence on the surface of the restoration, which maximizes the material effects. Now, the good news is it only takes about 4.5 to 5 minutes for this cycle to occur in a speed fire. You can use conventional ovens. It's in the instructions for use, but just expect a little bit longer firing times. And the outcome of this is it optimizes the crystal structure, increases the virgilite crystals, which enhances its strength, increases its material density, and it liquefies and heals any surface defects that may have occurred during milling. So this is a must. You must do the matrix firing. Now, what is matrix firing other than what it does? Well, first you can use either a spray or a paint-on glaze. They both work, same firing cycle, not a problem. The restoration, though, must be positioned in the optimum heating location within the speed fire. And that's what that honeycomb tray and the firing pad is all about. The honeycomb tray elevates the crown right into the sweet spot in the oven. The firing pad is put on top of it so that the glaze on the crown doesn't stick to anything. The other thing is, because heating of this is so important, you're limited to one restoration per sequence. But since it only takes 4.5 to 5 minutes, it's not that big of a deal. And keep in mind, this honeycomb tray and firing pan is only for the CEREC Tessera material. Don't put a zirconia crown on there, for example, and fire it. It'll melt. It's not designed to withstand those types of temperatures. And this allows us to create a very nice looking aesthetic result with a very efficient glazing process in a high strength glass ceramic. And because it's glass ceramic, you can easily bond it as well. Now, if you want more details on the CEREC Tessera, there's a couple of references. One is a white paper on the Dentsply Sirona website. The other is an article in the cdocs.com magazine from Q1 2020, and both of those you should be able to find online. Now, the other material that people are going to gravitate to for these short clinical crowns is a full contour zirconia. Now, both of these materials, the high-strength ceramics and the zirconia, allow us thinner reduction, as we talked about earlier. Both of them are the material categories that have the higher strength. Again, since we have less dimension, it's an advantage from that perspective. Now, a couple things about zirconia. One, has excellent physical properties. High fracture toughness, high hardness, high strength. But it has no glass, and that's important. People want to call zirconia ceramic. It's not. It's a polycrystalline material, has no glass in it. And that's important in how we handle zirconia when we go to deliver it. Now, we say that it's metastable because these different crystal elements can exist in different combinations, depending on how the manufacturer sets up their material. And why is that important? Because the process that makes zirconia have its strength is called transformation toughening, or TM transformation. Basically, what occurs here is if a stress is put through this tetragonal crystal phase, right, it has some energy on that crack as it propagates. And what happens is that energy hits these tetragonal particles, and the tetragonal particles shift to a monoclinic particle. Now, so what? Well, the so what is the monoclinic particle is 4% bigger in volume, and that puts a compressive load on that crack, preventing it from propagating. And that's where zirconia gets its strength, this transformation toughening. So to get the highest strength out of zirconia, you want all tetragonal crystals. The problem is tetragonal is not the best looking crystal. Okay, and that's where some of the early zirconias got that really opaque white look to them, very bright. It's because it didn't have any real translucency. So what companies have done, and this chart is just a really nice general categorization of zirconia. You see a 3-mol, a 4-mol, and a 5-mol. And what that's referring to is as the manufacturer shifts the type of crystal within its material, it uses a dopant, generally yttria, to stabilize it. And the amount that you add is dependent on the 3-mol, 4-mol, and 5-mol. Now, these are not exact, precise recipes. These are just general categories. You'll find a little variation within each category. But for example, a 3-mol zirconia, the high strength is over 85% tetragonal, great strength properties. On the other side of that is the 5-mol percent zirconia, which is about 50-50 cubic and tetragonal. Now, the cubic crystal is where we get our translucency from. That's where we get the really nice look from it. But the problem with the cubic is what? It doesn't go through the transformation like tetragonal particles do. And so you'll notice we have a reduced strength relative to zirconias. Okay, it's still high. It's over 600 megapascals, but it's a lot less than what you get with the 3-mol. And then the 4-mol, as you can see, is in between. It's got more cubic, obviously, than the 3-mol, less than the 5-mol. So manufacturers can dial in what they would like to optimize in their material. And so instead of having to memorize a bunch of different brands, if you remember the 3-mol, 4-mol, 5-mol, you have a pretty good idea of how that zirconia should be handled relative to dimensions for prep. The 5-mol is going to need a little bit more occlusal thickness than the 3-mol, and what it's going to look like. And so here's our chairside zirconias. You can see that most of our manufacturers have kind of gravitated to the 4-mol, which gives us a better looking material with a good strength property. And in that category, one of the newer ones is the CEREC MTL zirconia. It's a multi-transitional layer. So you have a color gradient within the block, which is a real advantage to zirconia because we're generally not going to stain and glaze zirconia in the posterior of the mouth because we know that zirconia can be abrasive. It doesn't have a very smooth finish. And the best finish we can put on the occlusal is a hand polished finish. So these are 4-mol zirconia blocks. It's got a high strength over 850 megapascals. And it's got a pretty fast zirconia workflow. And see, that's another thing to consider, especially at the chair side, is How does that high-strength ceramic like CEREC Tessera, which, as I mentioned, took a little longer to mill, but it's got a really quick matrix firing process. So all in, you're looking at 20, 22 minutes. Well, with the prime mill at super fast speed, we can mill a zirconia crown in less than 5 minutes. Sintering takes a little longer, but all in maybe close to 25, 27 minutes. So you've got a little bit of time differential there. Dentsply will recommend this as your better looking zirconia material. Okay, and then even in a hand polished state, you can see a little bit of gradient of shade there, which is an advantage of the NTL zirconia. The other newer zirconia that's been launched is CEREC Zirconia Plus, also by Dentsply. Dentsply would recommend this as your more strength load-bearing zirconia because it is a monolithic shade, not a multi-transitional layer as the other one was. It is not equivalent to CEREC Zirconia. Just for those of you who remember the CEREC Zirconia, it's not the same. CEREC Zirconia was 3-mol. You don't substitute it in the CEREC software. It's like, oh, that's the same as CEREC Zirconia Plus. No, it should say CEREC Zirconia Plus. And you can see here that the indications are also for 3 or 4 unit fixed partial dentures. Now, when you go into processing the zirconia, we know we're going to get a lot of shrinkage with it, 22 to 24%. And that's important to understand because that's what the barcode on the block is all about. It programs our CEREC machine software to expand the design enough so that when it's sintered in the speedfire oven, we get a really good result. And you can see the sintering takes quite a bit longer than the matrix firing did. But remember, we can mill these in about 4.5 to 5 minutes. So not a huge difference in the time it takes. One of the things that people talk about is because polishing is so important for the zirconia, and especially when you've got a short clinical crown, you're not going to probably take the time to do any kind of customization of color or anything. So this is going to be a sintered polish process. We know in this green state before it's sintering, it's a much softer material, much easier to polish and handle. And so some people advocate, yeah, let's go ahead and do the bulk of the polishing in this state before sintering. That'll make it a little bit easier than to do all the polishing after it's been sintering. So you take the sprue off, you get rid of some of the mill marks, but probably what's really helpful is taking a spiral polisher and gently doing the occlusal, because that's going to be the toughest part to polish after it's sintered, because it's got the most anatomy to it, and you don't want to flatten that out by having to use a big wheel or something. The challenge, though, is stay away from the margins. Here's an example from a microscope of what the margin would look like in a dry milled 4-mol zirconia. Very nice, clean margin. But look at what happened by just lightly adjusting it and try to polish it with a rubber wheel. Remember, zirconia is real delicate at this stage. So my recommendation is, yes, I think pre-polishing is a nice idea, especially on the occlusal surface. Maybe go down to the height of contour at the most, but don't approach the margins in any way, shape, or form. That'll ensure that you get a really nice fit and still get the surface finish where you need it against the opposing dentition. And you can see here just from a sintered example and a polished example, you get a very nice gloss finish in even the CEREC Zirconia Plus. You don't see the grading of color like you do in the MTL, but the surface finish can be very, very nice in zirconia. And just one little tip here, spend more time on the contouring, say the medium or coarse step, than on the final step. Because the contouring step is where you get the smoothness. If you spend a little time there, get rid of your mill marks, get rid of the grooves, do a nice job there, the final step is pretty quick. It'll bring up the gloss really fast. And you get a smooth surface. If you quickly go through the contouring step and focus on the polishing sequence, you're going to get the gloss, but you're not going to get rid of the roughness as easy because the final step is just about the gloss, not about making it really smooth. But one of the real nice features of these zirconias is look at the minimal reduction required for them. And so that becomes a real advantage on a short clinical crown. Instead of having, think about it, the adhesive glass ceramics needs 1.5 millimeters. We're at 0.6. We're almost maybe a third to 40% of the thickness, and we still get very good strength. And so that's why a lot of people have gravitated more towards zirconia for that second molar short clinical crown situation. Let's just take a couple of looks at some of the cases. Here's a second molar short crown. Looks like it's got plenty of occlusal dimension. We scan it. There's the preparation from occlusal. Taper doesn't look too bad. Maybe a little bit more taper on that distal than we'd like to see. But let's look at it in cross section and take out the distance tool and let's see what the heights of those walls are. So that distal wall is better than 3 millimeters. Okay, remember we talked we need a 3 millimeter vertical dimension to have retention. We look at that mesial. That looks pretty good, but look at the taper on the distal wall. It's probably a little bit over tapered, but at 3 millimeters, you're thinking, I think I could probably cement that, and you're happy with your zirconia crown. But keep in mind, technically, that probably wasn't a real retentive preparation, even though you had the 3 millimeters wall, because that was quite a bit over tapered to be geometrically retentive. Let's look at another one. Okay, taper looks good on this one, better on the distal than the last one did. There's the scan. Again, taper still looks good. Let's look at it in profile. And again, in profile, taper still looks really good. So what's our vertical dimensions there? On the mesial, we're looking at about 2.5 millimeters. And on the distal, we're about 2. Now the question becomes, is this really retentive? In our first example, we were already at 3. Yeah, the distal was a little over tapered, but we had a pretty good vertical dimension. The taper looks good here, but our wall of concern is only 2 millimeters tall. And this is what zirconia, I think, has bumped into. See, if I had a glass ceramic restoration here and I had plenty of occlusal, I wouldn't even worry about bonding this. I have plenty of tooth to get a good bond to it. But what about bonding zirconia? And I think that's been a big question in this short clinical crown. People like the thinner dimension on the occlusal that zirconia can offer. But when you get these short preps and you can't do a really nice geometrical prep for retention, can I bond it and get a good result? That's a great question. And that's one of the questions that this study tried to look at. It's a practice-based research network, which is a really nice type of study to do. Instead of it being a very controlled clinical study in a university setting or in a practice setting, that everything is controlled very carefully and it's prospective, it's all designed. This is basically going into private offices and say, tell us what you do. So here's 202 dentists that delivered over 3,400 single unit crowns. And they documented the type of cement they used. Now, what's nice about the study is then the lab techs who did the crowns evaluated the preparations when they were sent to the lab for fabrication. And then they had different factors that he identified, and we'll touch on these. A couple of general comments. 20% of the doctors said they bonded every crown they've done. Now, I don't know if that's high or low. I know that there's quite a few people who work with Chairside who are so used to bonding things, they just bond everything. Okay, it's a great way to get retention. 39% of the dentists reported they had never bonded a crown. Now that seems kind of high to me, to think that you would never bond any crown that you did. But obviously these doctors reported it that way. 60% plus of all the crowns were not bonded, and of those, 85% were cemented using resin modified glass ionomer. So the authors kind of alluded to this 39% report they had never bonded a crown as maybe the doctors weren't clear on the type of cement they used, because they even thought it was a little bit of a high percentage. But keep in mind that if 60+% of the crowns were not bonded, they must have had optimum geometric retention for cement to work. So that brings up the question then, why would I shift to an adhesive retention compared to cementation? Now we mentioned that in this case, 6% of the crowns had excessive taper. And when they compared bonded versus cemented, you can see that in the excessive taper group, considerably more were bonded than cemented. 9.7% of the crowns had short crown height, so basically 1 in 10. And you can see, if you had short crown height, they lean well towards bonding as well. What if you had excess axial reduction, as 6.9% of the crowns did? It wasn't significant. So the key here is the two pieces that influenced doctors selecting a bonded material instead of a cemented crown was crown height and taper, which if you think back to the beginning, we were talking about what made a really retentive prep. It's the same two things. So it's reinforced in clinical decision making by these doctors that yes, the two features that give us the best geometric retention for cementing, taper and crown height, are also the two features that when you don't get it, people kind of lean towards bonding things. So if you look at a prep like this, it's got good taper. We know the distal wall is always going to be limited by the tissue because as the ramus slants up there, it's not helping us. It's not dropping away from the cervical of the tooth. And so when we get that scan and we put it in profile and we start looking at our taper, you can see the distal doesn't quite have the type of taper we would like. We start measuring crown heights at 2.7 plus. That's a pretty good dimension. It's not 3, but it's close enough. But look at the distal. And I think this is where people really come into play is if I've got the thickness for glass ceramic there, high strength ceramic, I'm going to bond it because I know I don't have a retentive prep. And keep in mind, retention is based on the shortest wall, not the longest wall. People say, well, I got 2.7. That's pretty. No. Your prep is 1.75. That's not close to what you need for good geometric retention. And then when you happen to look at the type of material and how they were handled, well, those materials that allowed themselves to be bonded predictably, lucite reinforced and lithium disilicate ceramics, for example, 70% of those were bonded. Zirconia crowns, on the other hand, over 60% were cemented, but still 30-40% were bonded, which is a pretty healthy number, which to me really reinforces this problem that we have with short clinical crowns is doctors would love to use zirconia back there, but are realizing they're not getting a nice retentive preparation. So if we compare the zirconia preps to what we would have to do for a high strength ceramic, see, the high strength ceramic will give us different dimensions based on whether we're going to bond it or whether we're going to cement it. Because strength is an influencer on whether it can be cemented. It's got to be above about 350 megapascals for the ISO recommendation to say, yep, you can cement that. And manufacturers tend to hedge their bets a little bit and say, no, we need a little bit more thickness if you're going to cement it, because the material's got to be self-supportive. But if I'm going to cement a crown, I can do it with half the thickness in zirconia. Both the CEREC Zirconia Plus and the CEREC Zirconia MTL are less than half of that thickness. So that's an advantage to me if I can do a retentive prep. Problem is bonded. Now I'm only about 0.4 of a millimeter difference between a zirconia bonded crown and a high glass ceramic bonded crown. So let's talk a little bit about the bonding. If the material contains glass, like our glass ceramics do, we're going to etch it with hydrofluoric acid. Now, the only thing that will vary is how long you etch. You got to watch the manufacturer's recommendations because not all of them are the same. And then you're going to use a silane coupler on the rinsed and dried etched surface because that is what mediates the bond to the cement. You don't want to skip the silane. Okay, that's not helping you. Etching it is good, but the silane mediates the bond. Okay, now the good thing is this is very predictable. This is much stronger than the bond of the tooth, so it's a predictable bond force. On the other hand, if the material does not contain glass, which is zirconia, we can't use hydrofluoric acid. It won't do anything but clean the crown. So we're going to use air particle abrasion. Going to have about 30 to 50 microns of alumina. Going to use it at about a centimeter away, 30-40 psi, 10-15 seconds. Now you notice I'm not giving you exacts because really this is a cleaning step. And for me to tell you you should do it for 10 seconds, well, what if nothing comes out of your airline for the first 3 seconds? So it's more of a visual thing. You're just trying to clean the inside of the crown. You're not trying to cut it. You don't want to get really close. You don't want to use really high pressure. Okay, just a cleaning step so that you have a nice, rough surface to bond to. And then you need a phosphate monomer, because a phosphate monomer then mediates the bond between the zirconia and the resin cement. Now the question is, what's the phosphate monomer I should use to bond zirconia? Well, you have three choices. Chemically, they're essentially the same, but you got three delivery mechanisms. One is to use a marketed zirconia primer phosphate monomer, and that's the box to the far left. Now you notice that there's two silanes in there. Silane will not bond to zirconia because there's no silicon, there's no glass. But those also have phosphate monomers in them, which do react with the zirconia. We could use a universal adhesive. Many of those have 10-MDP, some have penta. These are, again, phosphate grouped bonding systems that allow us to bond to the zirconia. And these are obviously commonly used with dual cure resin cements. And then the third option we have is to use a self-adhesive resin cement, because most of those have 10-MDP also, or another phosphate group that bonds to the zirconia. So all three of those have the chemical agent we need to get a bond to zirconia. I wish I could tell you which one is the optimum one. They all work. We don't really have clinical evidence to prove one is better than the other one. So let's look a little further into this. So here's a situation. Here's another one of our second molars, short clinical crown situations. And there's the preparation. It looks pretty good on its surface. Okay, taper doesn't look too bad. Looks like we got a fair amount of tooth. Been some sort of a block out or a core material there, obviously. So here it is again, and let's look at it in profile. And you can see we're on the short side. We probably don't even have to measure it, but it doesn't look too bad. I mean, visually it looks shorter than what it measured out to be. So the question is then, what about the distal? And see, that's where we have a problem. Now, one of my first questions when I saw this case was, why put that composite in the prep if I already have minimal space? See, how is that going to help me solve this problem? It's going to take up space that I could use with either my zirconia or ceramic. And I would rather, if I'm going to have to bond it, which it looks like with a prep of this dimension I'm going to have to, why would I want to have an intermediary between what I'm bonding and the tooth? See, that composite is bonded to the tooth the same way that we're going to bond the restorative material, whether it's ceramic or zirconia. Well, getting a bond to an already cured and prepped composite, there's no reactive agent there. You're going to get just some roughness that you're going to get the cement to lock into. The better bond is to the prepped tooth surface, especially if you're doing it at the same appointment you're cutting the prep, which we do with the chairside system. So there's no reason to put that composite in there. Take advantage of whatever geometry is in that part of the tooth. You have a short tooth already. Remember, we talked about you could do some geometric aspect, put in some grooves, put in take advantage of the whole geometric piece that was the restoration. Let those walls work for you as well. Plus, take the advantage that you're bonding to the tooth surface, not the composite. Another example of a composite on a short tooth that's got quite a bit of taper, quite a bit of axial reduction. And you look at the taper on that distal. See, why put that composite in there? How is that helping when I've already got a short crown to begin with? The distal's 2.26 and the mesial is 1.8. Don't work against yourself by blocking out or using a core. Remember, the concept of a core means it is going to provide the primary retention for the restoration. How is that going to provide any primary retention? Especially if we look at it from the facial. You go, oh, look at, we got a lot of worm on the facial. Look, we feel really good, almost 5 millimeters. But it doesn't matter because look at what you got in the lingual. You're 1.5 millimeters. So your 5 millimeters feels good, but it's not an advantage because you're limited by the 1.5 on the lingual. And putting that composite on there isn't helping you either. You're just blocking out some potential geometry that could help in the resistance form and actually get you a better bond to the tooth than bonding the composite to the tooth. So if we're leaning towards adding adhesives to our high-strength ceramics and our zirconia to improve the retention. What do we do with zirconia? Now, this is an interesting study, getting a few years old now. They looked at all lab studies from 1998 until 2014. They found that air particle abrasion was important to get a bond. Now, a little bit of difference on how big the particle size should be, what should be the pressure, what should be the distance, all these kinds of things. But the bottom line is you've got to use air particle abrasion. Now, some people say, well, isn't that the same as just taking a diamond and grinding it? No, it's not. Because if you grind it with a diamond, you have the risk of creating some micro cracks in the zirconia, and that's not going to help us. And also, that roughness is too macro. You want a smaller roughness. It gives you more surface area. Now, if you don't do anything, I mean, if you just clean out with a little bit water spray or maybe a little alcohol or something, which isn't doing much other than just cleaning the debris out, your bond strengths are very, very low. So you're not going to get a bond. And that's what's always interesting when people say, well, I bonded the zirconia crown and it came right out. Well, the question I have is, did you really bond it? Did you go through the sequence of preparing the surface of the zirconia? We know that the adhesive monomers are needed to create the bonds. Some of the laboratory tests aren't really supportive of how long term those bonds hold up. And so that's the challenge with bonding zirconia. I believe we can get a bond to zirconia. Okay, there's too many laboratory studies that show it is possible. The challenge for us is we don't really have a universally accepted technique to get us clinically sufficient retention. We don't have clinical evidence. The evidence that's out there clinically deals with adhesive zirconia bridges, where you have one-wing bridges and you bond those in place. We have good success for that. It's a much different mechanical arrangement than what we're talking about on posterior teeth. All right, much bigger surface area, and we're bonding to enamel, which is always an advantage for us to bond to. In the posterior with the crown prep, we're bonding to dentin. So this is the problem I have in telling you this is what you should do. I can show you things from laboratory studies that are effective. I just can't show you one that you should do every single time. Because that's our challenge on the tooth. See, we seem to overlook this piece a lot when we talk about bonding. We get hung up on the restorative material, etching and air braiding, and what do we put on there. But this is the weak link when we bond. The bond to the tooth, or the bond to the zirconia and the high-strength ceramic is generally higher than when we get to the tooth. It's the challenge to get a good bond here. Now, we all realize that enamel is the best surface to bond to. If we put phosphoric acid on enamel, 15, 20 seconds, rinse it off, we're going to get a predictable bonded surface. But how much enamel do you end up with a crown prep here? I mean, you get a little ring at the mark. Is that going to really enhance our bonding by etching that amount of enamel? It's not going to hurt, that's for sure, but is it going to significantly overcome the limitations in some of the preps that we've been looking at? I would suggest no. I think we need to focus on dentin bonding. Because if we can't get a good dentin bond to these, we're probably not going to really enhance our adhesive retention either. Now, just to clear the air, well, I'm going to cement everything. I'm going to cut really nice preps. I'm going to put in accessory grooves and boxes, and geometrically, even my short preps are going to be worked with cement. Okay, that's a great approach to doing this. You focus your attention on getting optimally retentive preps, so the cement will work. But keep in mind, resin-modified glass ionomer is the most popular cement that we have. People think that they will work in a moist environment. They don't. We get away with it, but not because it's impervious to moisture. The only material we have that works well in a wet environment is amalgam. Okay, we know that has worked for decades. We don't use it near as much as we used to. All the adhesives we have aren't improved by having a little saliva there or a little bit of blood there. It doesn't work that way. And glass ionomer is no different. It is very, very soluble in moisture prior to complete curing. If you want a good example, take your favorite resin-modified glass ionomer, put it on a glass slab, put a couple drops of water on it, and watch it turn to milk. It dissolves very quickly. But it does set even in that environment. And so it would hold the crown in place on a good retentive preparation for the most part. But you don't have near the same physical properties. You still don't have the same potential that you would have in a better controlled environment. Now, the reason a lot of people like to cement it, I can do it quicker. I don't have to control the environment as long. Now, keeping things simple and doing them efficient is an advantage. That's not a disadvantage. Okay, I know a lot of people think about, well, if it's simple, it's probably not as good. No, no, no. The advantage of doing things simply is that you can predictably repeat them. Predictably repeating your process builds accuracy over time. If you have a very complex process, many, many steps, many, many products, the risk of being consistently accurate in that drop based on how more complex it is. So doing things simply and predictably is a great way to ensure an outcome. So it makes sense why people like doing cements. It's a simple process. Isolate the area you're going to, have a clean tooth, have a clean crown, mix the cement, put it in place, hold it for the specified period of time, and clean it up. You only have a couple things to keep right there. And so that's a great way to work. Just don't fall into the trap. Yeah, but it overcomes this kind of a limitation. No, it doesn't. You should really have the same attention to isolation and moisture control, even if you're cementing, for your restorations to work well. And that's a challenge, as we all know, in these short clinical crown situations. You're already several millimeters subgingival on the distal. Trying to keep that area dry and isolated for any length of time is a challenge. And that's where these self-adhesive resin cements can come in handy. Remember, glass ionomer has no bonding capability to the restoration, has very little bonding capability to the tooth surface. However, remember, our crown preps are primarily dentin. These are self-etching systems, which bond well to dentin. Their limitation is they don't do as good a job on enamel because we're not going to etch and use a bonding agent with them. So the enamel doesn't get the maximum bond. Well, in a crown prep that has just a very small ring of enamel at the margin, probably not that big of a deal. And that's why these can be very useful in these short clinical crown situations to get a bond in a shorter period of time than if you go through the total etch or selective etch process with a bonding agent with a dual cure resin cement. So you're in the clinical efficiency of cementing something like a glass ionomer, because these don't take a lot of time either, but you have the advantage of developing a bond to the dentin. And as a good example is the Calibra Universal by Dentsply. It's got a very good dentin bond, fair to enamel like we talked about. What's a challenge for a lot of people with resin cements is the cleanup. You know, they worry about, well, how fast is it set up? How hard is it to get that off? That's an obvious advantage with a resin modified glass ionomer. It cleans up very easily. And so does this. If you take just a minute or so after it's in place, it goes through a gelled state, which is a relatively firm material that's pretty easy to clean up. You could also tack cure it, okay, a little bit at each line angle in the first minute, and it would clean up pretty easy also. You don't have to rush to clean these up, all right, because you've already got them in place. The bond is developing. You don't want to start the moisture contamination, obviously, but they're as easy to clean up as resin modified glass ionomers, unless you're really slow and or you've already cured it. Then obviously that's going to complicate things for you. Now it will self-cure in 6 minutes, but any resin cement that has some degree of visible light cure should be maximally light cured. That's how you're going to get the most out of it. The infinite cure concept that I just need a little light to get it going, that's not going to get it, because the chemical reaction and the light reaction compete with each other. One doesn't compensate for the other. We want to maximally to go forward to get the most polymerization we can. And so that's why you want to put as much light on these as a dual cure cement as on a visible light cured cement. So we come back to another example of our short clinical crown situation here, another second molar. We look at the prep, even put a pin in this one, it looks like, in order to hold that course, or trying to build a lingual wall to have some resistance for it, some geometry to it. And you still realize you're on the short side. Well, something we talked about, and you can see here on the facial, enhance your retention with a groove. Now, in this case, this groove is only going to help mesial distally. And the discussion must have been, well, look, the facial and lingual look like they've got pretty good walls. Those will be retentive. Let's put the groove there so it doesn't rock mesial distally. Again, optimally, I would do that on the facial or lingual and the mesial or distal. So you have them at 90 degrees opposing each other, which would significantly shorten the radius that crown could come off that tooth. And again, could you tell what kind of cement was used? Obviously not. That's something that you could have used a resin modified glass cement, or you could use a self-etched resin cement there with no problem. So how do we put this together now? We talked about the restorative material. We talked about the importance of the prep. We talked about the bonding sequence and how they can interact with each other. So now I'm faced with this situation. I have a short clinical crown. Let's say I want to cement it. I've made my decision. I would rather cement things. Okay. Then in order to cut a really retentive prep, I'm going to need to take about 1 millimeter off the top. Granted, with some of the zirconias, I could be at 6/10 of a millimeter, but just for easy math, we're going to say 1 millimeter off the top. Now, I can't do that with an adhesive, with a high-strength ceramic. If I'm going to cement a high-strength ceramic, I could take 1.5 millimeters off the top because I need more thickness for strength. So if I'm going to cement it, zirconia is going to give me a smaller occlusal dimension while maintaining good strength. But to get that retentive feature, I got to go another 3 millimeters down the side of the tooth. And that's where a challenge can occur, as we've seen. Can I improve that by maybe getting 2 millimeters and putting some grooves in some boxes? Absolutely. How much is enough? That's the challenge I can't answer for you. I mean, it's a judgment. And we don't have definitive clinical data to show, oh yes, if you only have 1.5 millimeters vertical height and you put 4 grooves in, it's going to work as well. We don't know that. We know the grooves will improve the retention, but is it going to solve it all the time? That's an unknown. On the other hand, let's say we're going to bond it. Okay. Well, I would take 1.5 millimeters. We're going to go, we could maybe use zirconia to bond, but we're going to go with the high strength glass ceramic here. We're going to take a little bit more off the top. Now, how far down the side of the tooth do I have to go for retention? I don't. And that's the real advantage to adhesive bonding. We don't need that additional preparation down the side of the tooth. We could bond it right on the top surface. Now, you have to have a lot of confidence in your adhesive bonding technique and material to do this. Because you're thinking, well, gosh, if I just set that on top, isn't that going to slide around? Isn't it going to rotate around? No, because you're not trying to cut a flat surface. You want to have topography in it so that when you go to try that in, it centers itself and it doesn't spin. Yes, you could move it because it's not bonded, but you would have some resistance to that. It would key itself in place because you have topography. Then harken back to when I was talking about putting that composite in. Why do that? Don't. Let that internal dimension of the old restoration also improve your bonding by being able to bond directly to the tooth and give you that resistance in the prep to key it in place. So let's try to put a lot of this back together now. Okay. If we're going to focus on the tooth preparation and we're going to do a ceramic, all right, the advantage there is if we do an adhesive type preparation, we don't hardly need any vertical prep height. We just need dimension for the occlusal. On the other hand, for zirconia, we don't have evidence that those kinds of bonded overlays or onlays are going to have long-term retention. We don't know that because most of the clinical research when it was done with zirconia, the advantage of zirconia is its strength and people would rather cement it. Well, you can't cement it in those types of preparations. Bonding zirconia came along after the fact when people were trying to put them in places that didn't have a lot of space and they weren't having success. So could we begin to bond? All right, if we look at the restoration volume, obviously zirconia is our advantage here. All right, because we can get below 1 millimeter dimension occlusally whether we bond it or we cement it. Okay, with ceramic, nope, the millimeter is the thinnest you can get. because if you go below that, you're going to compromise the strength of that material. And if we look at the delivery technique, can you bond zirconia? Sure, I believe you can. I would love to see more long-term clinical research on posterior single crown restorations to give some, clinical evidence to that. But we know cementation is preferred, but clinically effective retention is going to require a good prep. And that's the advantage to the glass ceramics in that we've been bonding ceramics for decades. Think about an anterior veneer. The only reason they work is because we can bond them. Granted, a posterior crown is a different situation, but the retention you get from bonding can't be dismissed. We have a lot of evidence for that. So I think if you look at the ceramic side, the advantage is I don't need that vertical prep height. I do need a little bit more thickness if I'm going to cement it. So I'm probably not going to cement these on posterior teeth. I'm going to bond them all the time. And if I'm going to bond them and I have confidence in the retention, it kind of all plays together really nice. On the other hand, with zirconia, the advantage is its strength. We can do it in smaller dimensions. And I think I'm still going to defer to the cementation for predictability. I think the adhesive bond is a potential. I'd love to do some work in that area to see if I could replicate an adhesive type preparation for a ceramic and make it successful for zirconia. The other thing to keep in mind is zirconia is not an easy material to marginate and contour and repolish intraorally compared to a glass ceramic. And so doing some of these adhesive restorations with zirconia might be a little bit more of a challenge and may not be as easy to do and get a similar good result. But I think the take-home message here is pretty clear. How do you want to work is a very important feature to what you're going to do. If you don't have that confidence in adhesive bonding and you don't have the desire to focus on the importance of isolation and moisture control and manage that piece, you're going to end up doing the cementation and focus more on the preparation part. And on the other hand, if you're used to bonding and you do it and you have a lot of confidence in it, you're going to be much more inclined to do these adhesive type preparations, especially with the CEREC system, because you don't have to worry about the temporization process. That's a real advantage, I think, for the adhesive concept, is the ability to bond something the day you cut the prep. We don't have to worry about temporization. We don't have to worry about the patient coming back a second time. So I don't think there is a one right answer here. I think your skill sets and your preferences for how you would like to work are going to influence your outcomes. I think if you keep those in mind, though, you're going to have success. It's when you try to mix and match and say, well, I'm going to bond zirconia and don't worry about the prep, but I'm not going to focus on moisture control and do it that way. That's where I think you're going to have your problems. So thank you once again for taking the time to joining us at this Henry Schein webinar focused on solving the short clinical crown dilemma, how, why, and what we do. Again, I'd like to thank Henry Schein for inviting me to host this webinar for you. Hopefully there was some very useful information that you could take back to your clinic and utilize it. Hopefully if you have any questions, be happy to try to answer them for you online. You can find my email address at the University of Michigan School of Dentistry website. And I look forward to meeting you down the road. Again, thank you very much and take care.
Thank you so much for joining us tonight, and thank you for that wonderful presentation. We did record tonight's webinar and we'll email the recording sometime in the next week. We would appreciate your feedback via our survey that will pop up on the screen shortly. Thank you again for joining us, and we look forward to seeing you on future webinars.